صلوا على محمد وآل محمد. Assalamu alaikum, everyone. Thank you for coming out this early in the morning for today's event. My name is Yusra Shao. I'm a hematology and oncology fellow at Karmanos, Wayne State University, and I'm excited to be hosting today's program about breast cancer, dispelling fiction, and talking about facts and how the Islamic perspective plays into this. I have my co-host here with me.
Assalamu alaikum. My name is Iman Hazimi. I'm a primary care nurse practitioner. And we're here gathered to talk about the prevention and mammogram screening and why do we need them and what happens. So welcome everybody. Assalamu alaikum. Thank you for being here.
So if you will see in all of your seats, there is a survey. As we are starting out today's program, I ask you to please fill out the front part of the survey. There are pens at your desk, at your seats as well. That will help us gather some information of what our communities believe about mammograms, breast cancer screening, and so on and so forth. Today's event is hosted by Faith Community Health Initiative, and I'll let Sister Iman tell you a little bit about that.
So today's event is hosted by the Faith Community Health Initiative. It's a health committee that works with the IIA here to advance the physical, mental, and spiritual health of the Muslim faith community by providing resources, education, culturally sensitive trainings, and community engagement.
So 1 in 8 women will be diagnosed with breast cancer in their lifetime. And if diagnosed early, breast cancer is a curable disease. Despite this fact, I see in my own family and in my friend circle, many women choose not to get mammograms and breast cancer screening. So I really hope that in today's discussion, we will be able to dig deeper into the reasons why, what are the risk factors, how to know that you may or may not need cancer screening, and so on and so forth. So I would like to start out today's program with the recitation of the Holy Quran, and to do that, we have with us Sayyid Ahmed Al-Musawi, if he can please come up on stage to start out today's program. Thank you. صلوا على محمد وآل محمد.
صلوا على محمد وآل محمد. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. أقم الصلاة لدلوك الشمس إلى غسق الليل وقرآن الفجر إن قرآن الفجر كان مشهودا ومن الليل فتهجد به نافلة لك عسى أن يبعثك ربك مقاما محمودا وقل رب أدخلني مدخل صدق وأخرجني مخرج صدق واجعل لي من لدنك سلطانا نصيرا بسم الله الرحمن الرحيم أقم الصلاة الصلاة لدلوك الشمس إلى غسق الليل وقرآن الفجر إن قرآن الفجر كان مشهودا ومن الليل فتهجد به نافلة لك عسى أن يبعثك ربك مقاما محمودا وقل رب أدخلني مدخل صدق وأخرجني مخرج صدق واجعل لي من لدنك سلطانا نصيرا وقل جاء الحق وزهق الباطل إن الباطل كان زهوقا وننزل من القرآن ما هو شفاء ورحمة للمؤمنين ولا يزيد الظالمين إلا خسارا وإذا أنعمنا على الإنسان أعرض ونأى بجانبه وإذا مسه الشر كان يئوسا قل كل يعمل على شاكلته قل كل يعمل على شاكلته فربكم أعلم بمن هو أهدى سبيلا صدق الله العلي العظيم. رحم الله من قرأ الفاتحة تسبق الصلاة على محمد وآل محمد.
Thank you, Sayyid Ahmed. You know, in my experience going through training as a physician, as an oncologist, I've always been in awe by the resilience that I have seen in our patients who experience cancer, and especially our breast cancer patients, as they go through so many body changes with breast surgery, hair loss through chemotherapy, and how that affects their lives, their relationships, and also the stories of striving through that and coming out stronger the other end. So today I am very privileged to have two patients to share their story with us. And I would like for them to please come on stage and take a seat at the panel discussion here. Sister Zina Al-Hassan and Sister Ayat Bazi. And I would like Sister Iman to please guide the discussion.
So from a personal perspective, annual mammograms have been very important in my life because I have a first-degree relative, which you'll learn is, we have my mother's sister had breast cancer with mastectomy. So that leads to it being a genetic issue. So I've been getting mammograms since I was about 35 years old. From a professional perspective, I see that I give patients referrals often to get mammograms, and they come back in for checkups and they haven't done it yet. And I want patients to understand the necessity of getting that mammogram done and getting this early detection. So we have here today Zana Al-Hassan and Ayat Faraj, Bazi Faraj. I just want to say thank you both for being here to share with us a personal part of your life. We know what type of courage and strength it takes for you to have gone through the process at all, let alone sharing it here with everybody. So we'll start with Zana, if you don't mind. So tell me a little bit about your cancer experience.
First and foremost, Assalamu alaikum everyone, and I just want to thank the organizers of this panel discussion. Certainly in our perspective, it's about prevention and making sure that women and men get checked annually and take care of their health. That's why we're talking about it. It's to raise awareness. I just wish that there was a sea of people here that could actually listen, and I certainly hope that, I know it's being streamed, so I hope we have a larger audience online. So my experience started in January of 2019. Ironically enough, it was my scheduled annual mammogram, and I almost didn't go. You know, we all get so busy, it becomes sort of a nuisance in our life. Unfortunately, I hate to say it, but I'm going to say what needs to be said. And I almost opted against going to my appointment. And something within me provoked me and said, no, just go, just get it done. And so I did. After my mammogram, it wasn't, I want to say this because a lot of people assume that you feel something or something's there or there's a lump or you have to find something in order to get checked, and that is certainly not the case, and it was not the case in my situation. And so after my mammogram, the doctor came in and said, you know, I see something suspicious on the film. It's not a lump, but what she showed me almost appeared like salt scattered around my breast. And I say that because that's nothing, again, I could have felt or could have known. And so she explained to me that it looked precancerous at the moment, what she saw, and so she didn't confirm cancer at that appointment after my mammogram. Subsequent to that, I had a needle biopsy, which means they extract tissue from the breast and they test it. And so even after testing it, it still appeared to be precancerous, but they recommended that I remove that portion of my tissue, and then they biopsy it after surgery, usually. So subsequent to the needle biopsy, I was scheduled for surgery to remove what they presumed at the time to be precancer. Had my surgery and went in April for my post-surgery checkup, just to go over some details. So I went by myself. I wasn't expecting any sort of indication of cancer. And so the surgeon walks in and she says, we biopsied the tissue, and unfortunately we found cancer, and we have to go in again to remove a larger portion of tissue because, again, as I indicated, it was pretty much scattered around my breast. So I had a second surgery to remove even more tissue, and thankfully after that the surgeon told me she thinks that she got just about everything. It's DCIS, so ductal carcinoma in situ, which means that it's in the milk duct, it's non-invasive, it's an earlier form of cancer, so between stage 0 and 1. And so thankfully I did not have to go through chemotherapy, but I did have to go through radiation. And so I had about 16 bouts of radiation. It was done on a weekly basis, 5 days a week, until I reached my 16 radiation sessions. I'm sorry, I want to go through it a little bit more, but after my radiation, I was also advised that I would have to be on a drug called tamoxifen. And the reason for that is because my cancer was estrogen positive. So I say that, again, just to raise awareness once again that an increase in estrogen could result in cancer. And I'll let the medical experts talk a little bit more about that. So, for instance, all the soy products that we eat, that increases your estrogen levels. I just want to say that because a lot of us are not conscious of that detail. So I had to be on tamoxifen for 5 years. They say 5 to 10 years, but if you're postmenopausal, it's 5 years. I'm sorry, if you're premenopausal, it's 5 years. If you're postmenopausal, it's usually 10 years. I've taken tamoxifen now for 3 years. I have 2 more years to go. And alhamdulillah, I have to say I am in the best health of my life. I just want to say that, as mentioned by the doctor, there is definitely a cure so long as you catch it early and you take care of your health, and specifically why we're doing this panel, so that we increase awareness.
Thank you. Your story is very much needed to be known, honestly. I mean, the details of how you caught it and the details of the actual, it's not a cyst, it's not there, you're not just gonna feel it, is very necessary, so thank you. Ayat, I know you had a rough time, so so tell us a little bit about you.
Assalamu alaikum. I'm Ayat. So in November 2019, at 30 years old, I found out that I had stage 2 invasive ductal carcinoma at 19 weeks pregnant, which I was like in shock, I was numb. I found a lump, so I found it in my left breast. And right away, I called my OBGYN. I was flipping out. You know, in my back of my mind, I thought maybe it's breast milk. Like, you know, I had that before where like I had to go get some milk removed. But then I went for an ultrasound, and just by the look that the tech was giving me, I knew something was wrong. They kept apologizing to me, and I was confused. Like, why are they apologizing to me? Because I went through this when I was 16. So at 16, I found a lump. Alhamdulillah, at that time, it ended up being nothing, but no one apologized to me during my ultrasound. I didn't get that feeling that it was cancer. So the following day, I had my biopsy, same thing. They're apologizing. They ended up seeing some of my lymph nodes. So I ended up going to like my lymph nodes underneath my left armpit. And I remember going to the car and calling my mom, crying, like, I have breast cancer. I was like, no, like, what do you mean? I'm like, I know it. Like, why are they apologizing to me? Like, you know, they just kept saying sorry. And a week later, I got called in. And that's when I got the news that it was stage 2. It was stage 2. And at that moment, I didn't really care for myself. Like, I wasn't worried about myself. I was more focused on my daughter that I was carrying. Like, what's going to happen to her? Like, am I going to have her early? But alhamdulillah, I found a great team at Beaumont Rural Oak. So that's where I decided to get my treatment. And I found out that I did have early signs, and I seen it. A year before, I noticed that I was having leakage from my breast, and I thought it was for me breastfeeding my oldest, but it ended up being that it wasn't breast milk. You know, you can't still produce breast milk 3 years after breastfeeding. So in a way, alhamdulillah, my pregnancy saved my life. So if it wasn't for my pregnancy, I probably would have never known I was stage 2 breast cancer. I did 12 rounds of chemo, so I did 6 rounds while pregnant. I delivered my baby Mariam at 37 weeks, and then I did another 6 rounds a week after I delivered. In June of 2020, I had a double mastectomy with reconstruction. Alhamdulillah, I got good results from chemo. I didn't have to do radiation, so knock on wood for that. I was very happy. But I did have like 2 more surgeries after that. But with all of that, I did find out that I do carry a gene. So it's not the BRCA. I carry CHEK2. So CHEK2 is associated with breast cancer, thyroid cancer, and colon cancer. Thyroid cancer runs in my family. My youngest sister had thyroid cancer, and my aunt, Allah yarhamha, she passed away from colon cancer. So on top of having breast cancer, I now do yearly checkups for my thyroid, which I have to do, I recently just did a biopsy, but I have a cyst, but it came back benign, alhamdulillah. But I have to do yearly ultrasounds, and I have to do yearly checkups for my colon because of the gene I carry. With that, there's also my 2 other sisters. Since I found out about the genes, they also found out they carry the gene too. And my daughters have a 50% chance that they as well carry the CHEK2 gene as well. Just like Zana's situation, I am on hormone blockers. So I take tamoxifen as well, and I am on Lupron. So I'm on like medicated menopause for 5 years. But alhamdulillah, you know, I'm so grateful for my family, my mom, for always being there, for my mother-in-law helping me with a newborn. You know, it was a very tough time, like the first couple months of having my daughter. But alhamdulillah, I wouldn't have changed it because I had such an amazing support system. And I just wish that we had this when I was going through it, because I didn't know anyone who was pregnant with cancer. I didn't have anyone to like relate to or to ask for advice. I was the youngest one at my cancer treatment, so like it was like I would get looks at because it was like kind of like unheard of, like being pregnant with breast cancer. But I hopefully inshallah we could do more of this, and I could like talk to everyone more and answer any more questions.
Thank you. I hope you guys, you both know what incredible strength and courage, and how we are so in awe of your stories and being pregnant with cancer and going through what you went through. I mean, we appreciate, may God increase your health, both of you. May Allah bless you and protect your families, inshallah. Thank you very much. Okay. At this time, I'd like to ask Dr. Yusra to, you can go ahead and introduce. You guys can step down. Thank you.
Thank you so much, Sister Zina and Sister Ayat, for coming up and sharing your stories. And, you know, just like you said, I wish we had more of a support system, you know, from our own sisters and brothers as we're going through these things. And so if at the end of today's discussion, and hopefully in, you know, follow-up events like this, if we feel that there might be a need to create our own disease-specific or cancer support system within our mosques and our faith communities, that might be a beautiful thing that comes out of it. Not just talking about the medical piece of it, but also the spiritual piece, because alhamdulillah, we have this huge strength that is with us, which is the spirituality aspect that really does help a lot of us get through these struggles in life. So next, I'm really honored to have with us our guest speaker, Dr. Hadil Asad. Dr. Asad is Assistant Professor of Oncology at Karmanos Cancer Institute with Wayne State University. She focuses her practice in breast cancer, runs clinical trials, including phase 1 studies at Karmanos. So if you can please come up and share words of wisdom. Thank you.
Assalamu alaikum. I'm honored to be here with you today, and I want to thank Dr. Shao for inviting me, and just the wonderful patient panel that you had sharing your experiences. I think it's so important to share your experiences with everyone, so thank you for doing that. So I want this to be interactive. Please feel free to interrupt and ask questions at any point, okay? And I'm happy to answer questions at the end of the session as well. So I want to talk today about breast health, genetics, and family history, and why it's important to know your family history. You can go to the next slide, please. So as many of you probably already know, breast cancer is the leading cause of cancer in women. There's an estimated around 290,000 new cases of breast cancer that will be diagnosed in 2022, and it's the second leading cause of cancer-related mortality after lung cancer. Next slide, please. The death due to breast cancer has been trending down, and you can see that in the light pink. Since the 1990s, that's the second line, there's decrease in death rate due to breast cancer, and that's in part due to better treatment, but also because of early detection. Next slide. So cancer develops in a multi-step process. All cancer is genetic, meaning that it's a problem in the genes in one cell, where the cell acquires mutations, and these mutations make the cell immortal. Okay, so the cancer starts off as one abnormal cell, which has the ability to grow and to avoid cell death. Okay, and the way the cancer causes problems is that it can spread to other organs and cause organ damage by being there. So all cancer is genetic, but not all cancer is hereditary. And as you'll see in the next slide, hereditary cancer is when you have one inherited gene that's abnormal, and that's present in all of your cells, okay? And so these are genes that are either usually tumor suppressor genes, okay? So if you carry one abnormality, we have 2 copies of every gene, right? If you already carry one gene that's abnormal, it only takes that cell one hit or one mutation to cause a problem in that protein, okay? And that's the difference between hereditary cancer and non-hereditary cancer. Non-hereditary cancer, you will have 2 copies, 2 normal copies of the gene, and it essentially takes 2 hits or 2 mutations for that cell to have a problem in that tumor suppressor protein. But, you know, only 5 to 10% of breast cancers are hereditary or passed along. 90% of the time they're not hereditary, okay, which means that they're sporadic. The cancer happened. We don't know why the person developed the cancer. Then there's about 15 to 20% where we call it familial. Familial means that we see clustering in the family of breast cancer, but there's no genetic mutation predisposing that family to the mutation. And why is it important to identify hereditary breast cancer? Because it increases the risk of breast cancer. For example, the most common gene or most well-known gene is the BRCA gene, the BRCA1 and 2. This is the gene that Angelina Jolie had. It increases the lifetime risk of breast cancer up to 80%. So any woman has a lifetime risk of breast cancer of 12%. Just by being a woman. So 1 in 8 women will have breast cancer during their lifetime, but women who have a hereditary mutation or a gene that's passed along have a higher risk of breast cancer. The BRCA increases the risk up to 80%, but not just breast cancer, also increases the risk of other cancers like ovarian cancer. And you heard the story about the CHEK2 mutation. The CHEK2 mutation is a moderate or intermediate risk gene, increases the risk of breast cancer about 20 to 40%. And in addition, there's other cancers. So there's an opportunity to screen for breast cancer more than just with once-a-year mammogram, but also to screen for other cancers when we know about these genes. And that way we can prevent a cancer from happening or detect it early. And this is just showing the lifetime cancer risk for someone who has a BRCA1 or 2 mutation. Again, the risk goes up from 12% with a general population risk to 80%. Ovarian cancer increases from 2% to 40%. And then there's other cancers too. Male breast cancer increases as well with male patients or male carriers of the BRCA1 and 2 mutation. Prostate cancer also, there's an increased risk. So that's why it's important to know if someone has the BRCA mutation. For the person as well, because it affects their screening, and also there's a treatment implication as well. There's a new pill that we can offer patients who have this mutation and have breast cancer, but also for their family, because these genes are autosomal dominant, which means that every family member has a 50% chance of having that mutation. First degree family members, we're talking about, sisters and brothers or children. So it's an opportunity to screen the family members so that if we identify that they are high risk, that we can do either high risk screening or prevention and early detection. The BRCA1 and 2 mutation increases the risk of a second breast cancer. So if someone has breast cancer and was found to have the BRCA1 and 2 mutation, they're at increased risk of having a second breast cancer, up to 30% within the first 5 years of diagnosis, and up to 60% within their lifetime. So that's why some women who have these genes may opt for bilateral mastectomy. It's not a must that they have to have a bilateral mastectomy, but it's a consideration that they may consider it to reduce the risk of a future cancer. This is what we talked about. This is the family pedigree. Basically, it's a 3-generation pedigree, basically showing the family cancer history. And you can see the features of the hereditary or inherited cancer in the far right. Those don't skip generations, okay? So you find that the grandma has it, the mom might have it, and then the daughter has it. So they don't skip generations. That's a feature of hereditary cancers because they're autosomal dominant. The familial cancers tend to skip generations. And then the sporadic, which is the most common, you don't really have any family history sometimes of cancer. And this is what we talked about, where in all of these hereditary genes, whether it's the BRCA gene, the BRCA, or the CHEK2, or others, they're autosomal dominant, so the children have a 50% risk of carrying the mutation. We don't recommend, though, doing genetic testing for children. We don't usually do genetic testing for anyone younger than 18 because we don't act upon it at that age. But for those that are older than 18 or 20 and have a first-degree family member with that mutation, they can get genetic testing. One additional thing I want to mention is that we talked about it not skipping generations. So for example, if a person is found to have a mutation and the sister is tested and the sister is negative, then her kids don't need to get tested because it's not going to skip a generation. Again, the opportunities for managing patients who are carriers of the BRCA1 and 2, and I'm focusing on BRCA1 just because it's the most common, but certainly there's other genes that increase risk of breast cancer as well. We have increased surveillance, so high-risk screening, not just with once-a-year mammograms, but we alternate between MRI and mammogram every 6 months. That's high-risk screening. There's opportunity for prevention. It's not really chemo prevention because there's no chemotherapy, but tamoxifen. For someone who wants to preserve their breasts and has a high-risk mutation, we can give them medications like tamoxifen, even if they never had breast cancer, to decrease their risk of breast cancer in the future. And then prophylactic surgeries, of course, are a consideration, bilateral mastectomies. And more importantly, for BRCA1 and 2 is actually removing the ovaries, because ovarian cancer, there's not very good screening for ovarian cancer. So if someone has a BRCA1 and 2 mutation, it's more important to do oophorectomy or remove the ovaries, more important than removing the breasts, because ovarian cancer is usually, when it diagnosed, it's usually late stage, and the best is to prevent it. So this is just talking about again, the potential implications. So why is it important to do genetic testing to identify these mutations? First, we can identify treatment implications. So, for example, there are certain therapies that women who have a BRCA1 or 2 mutation might be more susceptible to, okay? There's a pill also only for BRCA1 or 2 mutation carriers who have breast cancer. So it has treatment implications. The other thing, it provides the opportunity for risk-reducing procedures and high-risk screening. Okay, and it provides patients, the family, the opportunity to also do genetic testing and find out if they're at high risk. So what are the red flags? What makes you suspect that there could be hereditary breast cancer? First, having cancer younger than the typical age. Average age for breast cancer is 60. It's still a cancer of the elderly. But if you have a patient or a person with breast cancer and they're younger than 50, you start thinking, could this be hereditary? And you actually should offer these people or patients genetic testing. If there's more than one cancer in the person, in the patient, for example, either they have bilateral breast cancer, so they have at the same time breast cancer in both breasts, or they have breast cancer at 2 separate times, 5 or 10 years apart. You know, this is a red flag that this could be something genetic. Also, rare cancers, like anyone with male breast cancer. So any male with breast cancer should have genetic testing. Anyone with ovarian cancer should also have genetic testing. Those are considered rare cancers, and these are red flags that there could be something hereditary going on. So how is breast cancer diagnosed? The most common way it's diagnosed is asymptomatic screening abnormality, meaning the woman has no symptoms and abnormality is identified on a screening mammogram. That's the most common way, and those are typically early stage. Or you can have a symptom present, and we'll talk a little bit more about what those symptoms could be. We do imaging, such as mammogram. It's always important to do both bilateral mammogram, okay? If someone's has a problem on one side, we always check the other side too, because you can have bilateral or both breasts to be affected. We can also do MRI or ultrasound. Eventually, you need a biopsy. You can't diagnose cancer just by imaging, okay? You do need a biopsy, and the biopsy then tells us, is this in situ or precancerous, or is this invasive, okay? And also the biopsy tells us the receptors, because there's actually 3 or 4 different types of breast cancer. Breast cancers are treated differently depending on the receptors. This is basically how a cancer looks like on a mammogram. So you can see in a background of gray or dark, that white is a mass. It has what we call spiculated borders, which are kind of like spicules coming out of it, and that's cancer. Or that's suspicious, I should say, for cancer. That requires a biopsy. You can see that women who have dense breasts, there's a lot of white. You can actually miss that white tumor. And so dense breasts increases the risk of breast cancer, but also can hide breast cancer. So these cancers can be hidden on the mammograms. So what about screening mammogram? When should you start and how often? There's actually differences in guidelines about when to start mammograms and the frequency of mammograms. But as you can see in the second slide, we follow the American Cancer Society guidelines, okay, which recommend that starting mammograms by age 40. Next slide, please. So starting your mammograms by age 40 and doing your mammograms once a year. There are other guidelines that have different recommendations. You can choose to pick which guideline you want to follow, but in general, we at Karmanos and most other cancer centers follow the American Cancer Society guidelines. Next slide, please. So if you have dense breasts, we talked about how it increases your risk of breast cancer, but also can hide or obscure a cancer on a mammogram. So what can you do? There's additional testing that you can do, such as a 3D mammogram, which is a tomosynthesis, okay? That's a higher sensitivity mammogram. You can do breast MRI, you can do a whole breast ultrasound, and we at Karmanos also have the soft view ultrasound, which is a whole breast ultrasound that actually was developed at Carmanos, and we're the first center in the US actually to have the soft view ultrasound. And it's higher sensitivity than a mammogram, but it's not used, as an alternative to mammography. You still have to have your annual mammogram or your mammogram once a year, but you can use the soft view or any of these modalities in addition to your annual mammogram if you have dense breasts. So what are the signs and symptoms? So these are listed, some of the signs and symptoms of cancer. Now, even if you had a normal mammogram, I had a patient with a normal mammogram in August, and she was found to have breast cancer in September. Even if you have a normal screening mammogram and you have any of these symptoms, you should seek attention. So some of these symptoms, the most common is a lump. It can be painful or it can be painless. The other symptoms include nipple discharge, especially if it's bloody nipple discharge. That should be an alarming sign. Change in the size or the contour of the breast. Sometimes skin can change, skin thickening. You can also have redness or pitting of the skin, what we call orange peel-like appearance. These are all signs of breast cancer, and these should be alarming. If you have any of these symptoms or signs, you should seek attention. So what are some risk factors? We talked about the genetic risk factor, which is non-modifiable, but there are certain risk factors that are modifiable. We're going to start off with the unmodifiable. So these are factors that increase your risk of breast cancer, and you can't really change them. Those are age. It increases as we age. Your family history, race. The DES is a treatment that they used to give mothers who were pregnant that increases risk of, if you were pregnant with a girl, increases her risk of breast cancer, but we don't offer it anymore. So I've never seen a DES-related breast cancer. Previous radiation therapy for those who have lymphoma, okay, and they had radiation to the chest, they're at 5 times increased risk of having breast cancer, and they should have high-risk screening. Any, early menstrual cycle or late menopause, and, lack of pregnancy or late pregnancies, those are risk factors for breast cancer. And the next slide will show us the modifiable, or what we can control. So these are risk factors that increase your risk of breast cancer that you can do something about. So obesity. Obesity actually increases the risk of breast cancer by 1.5 times the general population. Lack of exercise, lack of breastfeeding, alcohol at any level. Alhamdulillah that, we in our religion we don't drink. Hormone replacement therapy. Taking birth controls, there's slight increased risk, especially if it's hormonal, but this risk actually goes away if you stop for many years. Again, we talked about not having children, that increases risk as well. So breast cancer is not just one disease. There's actually 3 different types of breast cancer, depending on the receptors. The outcome changes, depending on, if this is a hormone-positive cancer, is this a triple-negative cancer? The treatment also changes, depending on these receptors. When you think about management, you think about early stage disease as stage 1, 2, and 3, where the cancer is located just in the breast and regional, or I should say with or without regional lymph nodes. And the treatment is curative, and it can include surgery, it can include systemic therapy and radiation. Once the cancer is beyond the breast and regional nodes, the treatment is, it's stage 4, and the treatment is, mainstay of treatment is systemic, which is anything you take IV or orally to prevent it from, progressing. And it has palliative intent, meaning that we can't cure still stage 4 disease. So in summary, all cancers are genetic, but only 10% of the cancers are hereditary. The certain mutations can increase the lifetime risk of breast cancer, and it's important to identify those mutations. Breast cancer risk factors can be modifiable or non-modifiable. In the modifiable ones, you have the opportunity to do something about them, so you can, reduce your risk of breast cancer. Screening should start at age 40 and be done once a year with mammograms. You can consider additional testing, like we talked about, if you have dense breasts, and workup of any symptoms, even if a recent mammogram is negative. And with that, I'm happy to take any questions. Yes? So we are in the process of getting a vaccine trial for high-risk breast cancer. So this is for women who had breast cancer and are high risk of recurrence. We're looking at a vaccine to reduce the risk of recurrence. So we're in the process of getting that. We don't have it open yet, but we're very excited about the potential of having a vaccine for breast cancer. And in the future, we might be even looking at it for prevention of breast cancer. At Carmanos, we do have a lot of clinical trials. At any given point in time, we have 300 clinical trials that are going on. Some of them are de-escalation studies, so we're looking at less therapy and whether we can preserve outcomes with less treatment. And some of them are escalation, so we're looking at additional therapy to improve outcomes for the high risk. So we do have, a lot of clinical trials. We consider clinical trials at any point in a person when they're diagnosed with cancer, and to see if they're a good fit for the trial, and if they're, interested in pursuing a clinical trial. Okay, you want to say that?
My other question was, if you start with mammograms like when you're 40, I know it's really minimal, like the radiation risk, but do you think one of the diagnostic tests has less radiation over time, like one is better? Because there's a few options now.
There's actually, our radiology society calculates the total amount of radiation anyone is allowed to receive in 1 year. And so, mammograms have very, very little radiation. They're less than even a chest x-ray as far as the radiation. And, there is no increased risk from radiation-induced disease with mammograms. And so that's why we feel that the benefit outweighs that risk. Even for some people, we do CT scans every 3 months, for example, if they have advanced stage disease and we're monitoring for response. And that has a lot more radiation. There are, screening without radiation, that's an ultrasound. MRI has no radiation either. The soft view, which is a 3D ultrasound, also has no radiation. But right now, they don't replace the screening mammogram. They're to be used on top or in addition to a screening mammogram for dense breasts or
Okay,
high
yeah.
risk.
That was my next question, was could I get just a 3D ultrasound and forego the mammogram, but we should do...
You should still do
Gold
your
standard.
yearly mammogram because that identifies any abnormalities. Also, calcifications, which is a sign of cancer, doesn't appear on the other modalities.
All
So that's why you can't see calcifications on an ultrasound.
Thank you.
So inshallah, right after our panel, because we still have some speakers, we're going to take more questions. Thank you. Thank you, Dr. Assad, for providing us with so much education that's useful and telling us so much more about breast cancer. At this time, we welcome Dr. Haidar Hamoud, Chief Medical Cancer Physicist at South Suburban Hospital in Chicago, to speak about the radiation and breast cancer. Sallu ala Muhammad wa ali Muhammad.
Assalamu alaikum, everyone. My name is Dr. Haidar Hamoud. I'm specialized in the medical physics of cancer, specifically in the radiation section. Most of the people, they do not like to hear the word cancer. In fact, in our communities, they just call it that disease or haydak al-marad. Cancer itself and in general does not kill. What kills is the spread of cancer, intishar al-marad. The spread of these cancerous cells to the normal tissues and then to the critical organs like the brain, the liver, the lungs, the bones, then it becomes life-threatening. But if we catch it at early stage, right at the beginning, cancer is just like any other disease, if not easier than some others as well. Cancer has been around for more than 2,000 years. Not only women get breast cancer, but also men. Men can get breast cancer. And guess what? They also have to go and do mammograms. I see you all smiling now. 99% of the breast cancer patients are women and 1% are men. And it could be tougher in men. Let's take a step back for a quick minute to understand what cancer is and its type of treatments. As you all know, the body is all made up of cells. And you need about 1 billion cells put together in order to form the size of the tiny tip of a pen. But if one cell get damaged or mutated, or its DNA get changed by somehow, it will become a crazy cell. Next slide, please. This crazy cell is not gonna follow the orders from the body anymore. And it will have only one function, which is to kill or hurt its sister cell. And then its sister cell will do the same thing until billions and billions of cells, they get damaged, and then they will form a mass. Next slide, please. This mass is what we call it a tumor, waram. If this tumor is cancerous, then we call it a cancer, or malignant, or khabith. If this tumor is not cancerous, then we just call it benign, hamid. So we have khabith and hamid, a cancer or malignant and a benign. If it's a benign, it does not spread. All what it needs, in general, some medications, small surgery, and it's done. If it's cancer, then it will require the treatments. 80% of these breast tumors are benign, hamid. Only 20% are cancerous. If it's cancerous, there are many different types to treat it. But the main ones, the three common ones that we know, is the surgery, chemo, and radiation. You can go to the next slide, please. So these are tumors. Could be cancers, could be benign. So there are three common treatments: the surgery, chemo, and radiation. For the surgery, the surgeon will come, opens the breast, cut the tumor, remove it with some margin around it, and close it. Or in some cases, the surgeon will need to remove the whole breast. And this is what we call it mastectomy. For chemo, it's pills and medication through the blood. The medication go through the blood system, and those chemicals will look for the cancerous cells, will look for them, catch them, and kill them. But at the same time, they are affecting some normal cells. They're killing some normal cells in the blood system. And that's why the body will feel fatigue, tired, no energy, weak, to a point that even the hair will fall off. But it's very effective treatment. For radiation, it's a little bit different, and that's what I'm going to focus on for the next 3-4 minutes. Radiation is more like a local treatment, mawdi. That means if we're treating the breast, we are only treating the breast. The hair is not going to fall off because of radiation to the breast. If we're treating the brain, it's not going to affect the breast. It's more like a local treatment. So the purpose of radiation is killing the cancer, killing the tumor, stopping the growth of the tumor, and the tumor will start shrinking. And then the surgery comes, and the surgeon will remove it. The cancerous cells are so small that we cannot see during the surgery, and they are called microscopic diseases. Because we don't see it, then radiation can kill them. Only 50% of the breast cancer patients receive radiation. In fact, patient will receive about 16 plus 4, about 20 treatments, or could be 25 plus 5, that's 30 treatments. When we say 20 treatments or 30 treatments, that's 20 days or 30 days. Patient will be treated 5 days a week, Monday, Tuesday, Wednesday, Thursday, and Friday, and then we'll take 2 days off for the body to gain the energy back. Same thing for next week, and this will happen for 4 weeks to 6 weeks. Patient treatment or the breast treatments takes about 10 to 15 minutes from the time the patient walks inside the treatment room to the time the patient walks out the treatment room. Can put next slide, please. And the patient will lay back on a table of a machine. These are expensive machines, $3 to $4 million each, usually with arms up. And you can go back to the next slide. Arms up, and they use some immobilization device so they don't move. Because when I design the treatment plan for radiation, I usually work within 1 millimeter or 2 millimeter tolerance based off the CAT scans, MRIs, PET scans. When the patient is on the table of the machine, she's not gonna see anything. She's not gonna feel anything. Probably she will hear just the buzzing of the machine turning around her. The radiation is usually on for 30 seconds or 45 seconds. That's it. For the first 2 weeks, patient will not notice any significant change at all, just like taking x-rays. But the third week, fourth week, patient will start noticing some redness on the breast tissue. That's because of the radiation. Some swelling at some point, tender breast or sore arm and sore breast. She will feel fatigue. But it's a little bit different than chemo. It's more like a local, so the tiredness is way less. These side effects will go away in the next 3 to 4 weeks after treatment is done. These are called short-term effects. At some point, there might be some late side effects, and this could be years after the treatment is done. And these are specifically for the heart and the lungs. Because it's a local treatment, we are treating close to the lungs and close to the heart. If the heart and the lungs get more dose than the normal, patient might have some complications in the future, but these are taken into consideration when planning. So the heart and the lungs, or most of the lungs, will be blocked, will not receive more than the normal dose, and they should be fine. Is patient radioactive? Is patient radioactive when receiving radiation? Actually, no. So patients do not have radiation in their body. They can be with pregnant, they can be with kids, and it's not gonna affect them. To conclude, radiation treatments became so important and effective in treating breast cancer to a point that 100% or early stage breast cancer can be almost 100% cured. And even stage 2 and stage 3 are way better than years and years before. That's why screening is very important. Time is so sensitive and critical. Follow up with doctors is very important. And as I always say, and everyone say, dirham wiqaya khayrun min alf ilaj. An ounce of prevention is better than a pound of cure. Wassalam.
Thank you, Dr. Hamoud, for walking us through what radiation involves. And definitely radiation has allowed us to do more and more of lumpectomies and remove a smaller part of the breast rather than removing the whole breast and do breast preserving surgery that way. Next, I would like to invite our final speaker, who requires no introduction. Sayyid Hassan Qazwini is the Imam of Islamic Institute of America, and I invite him to the discussion table here for a back and forth discussion about the Islamic perspective of breast cancer screening. Sayyid Hassan, in your loudest salawat. Allahumma salli ala Muhammad wa ali.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله الطيبين الطاهرين. My dear, let me say sisters today because sisters are the majority. My dear sisters and brothers, Assalamu alaikum wa rahmatullahi wa barakatuh. First, I would like to thank the Health Committee at the Islamic Institute of America for putting this event together. My dear sister, Sister Maya Murtada. And I would like to thank all the panelists who participated in this very informative session. In fact, I believe this is one giant step toward educating our community about things that many families, many women in our community take lightly. So I truly appreciate the effort done by this committee to educate our ladies, our sisters in the community about the dangers of breast cancer. And by highlighting the fact that screening is extremely important for our ladies. I'm asked to speak about the topic from a religious point of view and to discuss how important, from a religious point of view, to have a regular screening. Well, there is an ayah in the Quran that basically sheds a lot of light on how we need to handle our basically caring for our own health. Allah subhanahu wa ta'ala says in the Quran, وَلَا تُلْقُوا بِأَيْدِيكُمْ إِلَى التَّهْلُكَةِ. In the Quran, God did not mention breast cancer, but this ayah speaks in general about how once we are exposed to any threat that endangers our life and put our life at risk, we have to handle properly. Allah says, do not cause your destruction with your own hand. وَلَا تُلْقُوا بِأَيْدِيكُمْ إِلَى التَّهْلُكَةِ. And not having any preventive, not taking any preventive measures by the patient could be deemed as causing my own or their own destruction. So definitely, all those preventive practices that are recommended by doctors are important and Islamically are recommended to be conducted, because we have one golden rule in Islam that says preserving one's life take precedence over everything else. Saving someone's life is more important than any other practice, even salah. If I enter my salah, if I am praying, and at the same time I see a child drowning and his life depends on me saving him, I need to interrupt I must interrupt my prayer and go and save the life of that child. Because saving someone's lives take precedence over all other issues and principles. Based on that, I do recommend that our ladies in the community do those screenings. When our sister Dr. Hadil was talking about the 5 tips given to ladies to prevent breast cancer, I took some notes. So one of them is to avoid obesity. Islam supports that. The Prophet says, al-ma'datu baytu da wal-humyatu ra'su dawa. The stomach is the home of all sicknesses, and diet is the top medicine. So obviously, Islam encourages Muslims to be moderate on their diet, and be careful and try to, as much as they can, avoid obesity. Alcohol. She mentioned that alcohol consumption can lead to breast cancer. Again, Islam completely prohibits alcohol consumption for all Muslims. Another tip she mentioned is breastfeeding. You know how many hadith from our imams that was before any scientific findings would come out and prove that breastfeeding is necessary for women to avoid breast cancer. How many hadith we have emphasizing breastfeeding, that a lady is encouraged, highly encouraged, a mother who gave birth to a newborn baby is encouraged highly to breastfeed her baby, even if there are other alternatives available. So this is one of the things that Islam emphasizes, that women would do breastfeeding rather than rely on other alternatives, such as formula or even just milk in the refrigerator. My other approach was, the other question that I need to address today, my dear sisters and brothers, is when it comes to a woman seeking medical treatment, whether in cancer treatment, breast cancer, or any other field, to what extent they are allowed to seek medical help from a male doctor. Before I indulge in that, let me just say this briefly. Some may say, what's the big deal? A male doctor or a female doctor? Doctors take oath that they would respect all moral values once they graduate, not to breach any trust in them, and the whole process is desexualized. I do understand that, and I can say 99% of doctors are trustworthy, and they handle their career professionally and respectfully. However, the problem is with the other 1% who sometimes prey upon their patient. You always read in the newspaper or you hear in the news about doctors, male doctors, assaulting their female patient. Sometimes it goes beyond physically assaulting their patient. It goes too ugly that basically becomes a huge scandal for not only the doctor himself, but for the medical institution he works for. I don't know if you remember 3-4 years ago, a doctor in Johns Hopkins University was found or was caught having a small camera hang on his neck in the form of a pen. And someone suspected the reason he is carrying this pen all the time around, especially when he sees his female patient. And then they found out that this is not a real pen. This is a camera he was carrying, videotaping his female patient when he was basically checking them. And when the FBI raided his house, they found over 300 video films that this doctor made out of his own female patient, put all in desk in his computer. And that doctor ultimately committed suicide and he died. But there were a huge lawsuit against Johns Hopkins because of that incident, because it involved over 500 patients who felt violated. So this is why we think that it is best that women take, a extra caution by not seeing a male doctor to begin with. So, however, there are certain loopholes. A woman, a Muslim woman, is asked and encouraged not to see a male doctor unless her treatment depends, and I underline the word depends, meaning as long as there are alternatives, there are female doctors who can see her, then her treatment does not depend on this doctor. But when there are no other female doctors available, and seeking medical treatment solely depends on her seeing this male doctor, now this is a medical necessity, and Allah subhanahu wa ta'ala permits medical necessity to prevail and to take place, because again, I go back to the golden rule I stated before, that saving someone's life takes precedence over all other considerations, including not being seen by a male doctor. So, if that's the case, then it is okay. And this is why I always encourage our female sisters who are seeking higher education in our community, that go and specialize in fields and in careers that that you can serve the women of our community. For example, by being OB-GYN or cancer treatment, breast cancer treatment, or all other fields that basically women need to seek medical treatment. I would encourage our sisters in the community to consider that career, because this has been a problem in our community for years. And I am being told that some ladies in our community, once seeking a female doctor, it may take them more time and effort to find someone good and professional to basically turn to. So I believe if we can educate our female students to seek higher education by seeking those medical fields, I think this will definitely solve many other problems we are having. Finally, I would like to thank you all for inviting me, for being with you today. May Allah bless you all. May Allah accept your deed. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Sayed, for your time and for participating in today's event. Next is the Q&A session. So if I may ask Sayed Hassan, Dr. Hammoud, and Dr. Assad to join here on stage for the panel discussion and Q&A. If you feel comfortable asking questions live, we have a microphone in the audience. Otherwise, you could send your flashcards up that you have at your seats, and we will ask the questions on your behalf. And then the online audience can type up the questions in the chat box, and we will ask those as well.
I do have an online question I'm going to be asking. The first question is, I have 2 lumps, one on each breast. They cleared it and it's benign after 2 years of monitoring. Would you suggest the lumps be removed? Are those lumps at risk for developing into cancer?
Assalamu alaikum. So if the 2 lumps were evaluated and on imaging appeared to be benign, then it's not necessary to remove them. If they have any suspicious features on imaging, the radiologist will recommend a biopsy. Sometimes they recommend closer monitoring, so rather than waiting a whole year to do something in 3 or 6 months. Also, how lumps change over time is also an indication of whether they are cancer or benign. Cancer is not going to stay, without growing or changing for months or years. Benign lesions do. And in general, you don't have to remove benign lesions unless they are bothering you for any reason. They're causing pain, they're causing deformity. You can choose to remove those lesions and seek a breast surgeon in those situations. But again, if on imaging there's nothing suspicious, then you don't have to remove benign lesions.
Thank you for a great program today. My question is to Dr. Assad. You mentioned that the general recommendation for screening for breast cancer is at the age of 40. How about if a woman was diagnosed with breast cancer at an early age, before 40, when is the recommendation for screening for her family members?
That's a very good question, and I did not mention that, but it's 10 years before the woman was diagnosed. So if she was diagnosed younger than 40, you just start screening for her first-degree family members 10 years before she was diagnosed.
Good question. We have 2 written questions. This one's for Dr. Haidar. You mentioned there is 20 verses, 30-day treatments. Are there new techniques available for faster treatments?
Actually, yes. Years before, it was 25 plus 5. That's the standard. Then for the last few years, they started with the 16 fractions. That's called like the Canadian technique. Nowadays, we have faster ones. It's about 5 fractions only, 5 treatments. So instead of giving low dose over many days, we're just given 5 days with a very high dose. For example, instead of 200 centigrade over 30 fractions, we're just given 5 days of 600 centigrades over 5 days only. Yes, and these are for partial breast. They're called accelerated partial breast irradiation.
A follow-up on that says, chances of cancer comes back after treatment? Question mark.
Yes, actually, we treat cancer with radiation, but at the same time, radiation can also cause cancer. The recurrence can be very low, could be between 3% to 15% that it will come back, but it's very low.
I want to just add, everything is a calculation of risk and benefit, okay? So, we still believe that if radiation is indicated, that the benefit outweighs the small risk of having, God forbid, a cancer due to the radiation. I also want to add that I agree with Dr. Haidar's statement that majority of early stage breast cancer are curable and that the cure rate is increasing. Okay, so that's because of advancements in technology, advancements in treatment. We can cure the majority of early stage cancer, and the treatment is easier the earlier the cancer is detected, and the cure rate is higher. That's why we like to detect cancer when it's earlier stage, so stage 0 or stage 1.
Thank you. I have a question for Sayed Hassan. Let's say we have, this is in regards to the male-female relationships or in the office. When someone's going to get a breast cancer or a mammogram screening, and they are unsure if there is a male personnel in the office. I'm not sure that there has been. I have been having mammograms there. I haven't seen male workers, but just in case. What is the ruling on, or should I not get a breast mammogram because I'm worried that a male may be in that office while I, have to expose myself?
Well, your responsibility is to request that no male should look at those images. But if the answer is the only person who is going to check those images is a male technician, then this is beyond your responsibility anymore. But it is our priority is to make sure that a female technician would check those images. Unless we exhaust all those possibilities, then it would be okay for a male doctor to check those images.
So just to clarify, that should not stop us from getting a mammogram?
No,
Okay.
that shouldn't stop you, because especially if it is recommended by a doctor, your own doctor, that this is important for you to do, and it is a preventive measure for breast cancer.
Assalamu alaikum. Thank you so much for this presentation, very much needed. In regards to the maternal side of the family, would breast cancer genetic testing be recommended if there is breast cancer in the family?
Both sides of your family are important. Your maternal and your paternal family history are important, because you can have the gene mutation be on your father's side of the family or your mother's side of the family. That's why it's very, very important to know your family history. And also, if there's a young woman with breast cancer in your family, I agree with what was mentioned about cancer being a taboo. People don't like to talk about it. There's a lot of guilt and shame when someone's diagnosed with cancer, and that should not be the case. First thing I tell my patients, it's not your fault. You got cancer. It's nothing you did or didn't do that led to this. And it's important for people to talk about it. If, you or a family member had breast cancer, any type of cancer, mention it to your other family members, because it might qualify them for genetic testing. If you yourself had genetic testing and were found to have a mutation, then you are obligated to inform your first-degree family members, which are your sisters, your brothers, your parents, if alive, and your children. In the medical field, we are not allowed to bypass the patient and inform the family. It has to actually come from the patient, and they have to inform the family because it gives them the opportunity to get genetic testing.
On that note, actually, can you give some advice from the Islamic or the medical perspective on how the support family members should handle somebody with a diagnosis of cancer? Many people don't want to share that information because they feel that they're going to be pitied. So what advice from an Islamic or medical perspective can you provide for the family members dealing with somebody who has cancer?
I admire those family members who are very open-minded, humble, and compassionate, and who do understand how tender those patients are, and how delicate the situation is, and how much in need they are of a support system. I have seen the opposite. I've seen men not being supportive at all, and the minute he finds out that his wife is having cancer, and I'm not saying this as a joke, this is a reality, I've seen it myself. The minute he finds out that his wife is having cancer, and it could be, I would say, really serious, he would think about his next marriage. And they go searching for another wife while his wife is too ill. I think this is totally immoral. It's totally against what Islam teaches. Allah subhanahu wa ta'ala describes the relationship between a husband and his wife is وَجَعَلَ بَيْنَكُمْ مَوَدَّةً وَرَحْمَةً. He made between you intimacy and mercy. And mercy is to be compassionate when my spouse is in need of my emotional support.
I just want to add that, alhamdulillah, in our community, we find that the majority of the family is supportive. We have a large support system, whether it's family or non-family members in the Muslim community. You know, I feel very, bad for patients when they come to their clinic appointment by themselves. I think it's always important to have a companion, have someone coming with you, a second pair of ears to hear what we have to say, to just show that support. And I would say that from my patients, what I see, the Muslim patients, that usually you have, you can sometimes have a room full of people. We don't want that either, because that can also be distracting. But, it's important to have a good support system, because when someone's diagnosed with cancer, it's not just the patient that's going through it, it's the whole family. And luckily our treatments are long, but they are, pretty effective. There's a lot of research being done in breast cancer. There's a lot of evidence supporting the treatment. So although it might be prolonged, 5 months of chemo, and then 1 month or 1.5 months of radiation, and then surgery, the treatments are pretty effective that, more than not, the patient or person will not have to deal with the cancer, after completing all the treatment again.
Thank you. Just to reiterate, you had mentioned that radiation has a very, very low chance of causing cancer, but we got a couple questions about that. Can you restate those comments?
Yeah. So, women or people who have lymphoma, for example, and they need to have radiation we call it mantle radiation, or to this area, they have an increased risk of breast cancer. This isn't radiation for breast cancer, this is radiation for lymphoma. And typically it's Hodgkin's lymphoma, so women who are diagnosed with that when they're in their 20s or 30s and have had radiation for that, they are increased risk of breast cancer. They have to have high-risk screening, okay? But we also see a very, very, very small risk of another type of cancer called angiosarcoma in women who had breast radiation. It's extremely, extremely rare. I've only, in my practice, seen 1 or 2 patients develop it in over, 700 patients a year. So it's extremely, extremely rare to develop, a secondary cancer due to the treatment. Again, we always calculate the risk and the benefit of having radiation and preventing the cancer from coming back outweighs that small risk that it carries.
Yeah, I can add something. So the risk actually depends on the dose and the area received by an organ or a body. And that's sometimes if you're treating an area and then it's close to another area, there might be like a secondary cancer caused by this radiation if the tolerance dose exceeded. Someone was going to ask about the extra dose of radiation and if it can cause like another cancer, especially when Dr. Hadid mentioned about the low doses from mammograms and X-ray machines. And the ultrasound, MRI, they don't have radiation. But when we talk about radiation, we are talking about a tolerance dose that organ can tolerate. For example, if you're going to get mammograms or CAT scans, these are low doses. It's not gonna trigger the threshold of affecting that structure unless it's more and more repetitive scans. Then you'll accumulate that dose, and then they will start affecting or creating or causing another cancer.
I just want to add, alhamdulillah, to have physicists who actually calculate the dose of radiation that that organ can get, and also estimates the scatter radiation that other normal organs may get, and ensures that they stay away from the heart. For example, for a left breast cancer, they stay away from the lungs, or limit the amount of radiation that the lungs will receive. It actually takes about a week or two before you finalize a radiation plan, because there's a lot of people that have to work on the radiation plan to finalize it, to make sure that it's effective for the area they're targeting and limits exposure to the normal areas.
And sorry, one more point about also, that's a good point you mentioned, and for the sister who was pregnant, and usually the doctors avoid radiation to the breast if someone is pregnant because of the scatters. That means when you're given radiation, there might be like some electrons or protons or neutrons or X-rays scattering left and right, and it might go to the other near structure or to the baby, for example.
Yeah, my question was just about the genetic testing that you guys were talking about. Like, let's say that my family, I don't have like a first degree or second degree that does, but they don't test. How can I get some genetic testing? Like, can I get it from my primary care, or is that available from my OB doctor?
So we wouldn't recommend that, general population have genetic testing unless there's a red flag. Okay, of course, someone with breast cancer, if they meet criteria, and the criteria has gotten a lot more broader. Anyone with breast cancer who's younger than 50 qualifies for genetic testing. And, if they have stage 4 breast cancer, they qualify for genetic testing. So I would say the best person to test is the affected family member. That's the best person to test. Now, if a non-affected family member wants to seek genetic testing, they can meet with a genetic counselor, okay? They can go through their family tree, the cancer family tree, as much as they know, and then they talk to them about what is your chance of having a genetic mutation, what is the pros and cons of genetic testing, and whether or not you meet criteria. Now, I have to mention that even if you don't meet the criteria for genetic testing has gotten very affordable. Without insurance, it's about $200, maybe $250. It's still, we do follow the guidelines. We do want to follow the criteria for who qualifies for genetic testing. But if you are concerned, then meeting with the genetic counselor and talking about your risk of having a genetic mutation, whether you should get genetic testing, might be worthwhile. We do have a genetics center at Carmanos, and you have to be referred by your primary care to get genetic counseling.
Thanks. Thank you.
We have one more question. We heard there's a Gallery test for early cancer detection. Does it help detect breast cancer, and who do you recommend for it?
Sorry, what's that? What kind of test?
Gallery test, Galleri. Does that sound familiar? Does the person who wrote the question want to elaborate? Okay.
So it's a genetic testing where they do blood work. And I think right now there is a clinical trial going on at Henry Ford Hospital. I'm not sure if it's also going at other centers like Carmano Center, but they said it helps to detect 50 types of cancer. So I'm not sure if breast cancer is one of them.
I would say that this is probably still part of a clinical trial.
Okay.
So we wouldn't recommend it outside the clinical trial because we don't know if there's evidence that supports its use.
Okay.
So I always encourage people to consider clinical trials. And if this trial, it's available to you, then I would strongly encourage you to pursue it, because then we would have more information on whether this test is actually helpful.
Thank you.
Any other questions? Sayyid Hassan, can you give us some closing remarks regarding the Islamic perspective about illness and treatment?
Islam takes a very proactive role in encouraging Muslims to always watch out for their health and for seeking medical treatment once it is needed. It's been reported that Prophet Moses got sick and he told Allah subhanahu wa ta'ala, لن أرى الطبيب حتى تشفيني. I will not go to the doctor till you will be the one who would heal me. Allah answered Prophet Moses, إني لن أشفيك حتى ترى الطبيب. I will not heal you until you go and visit the doctor. So this is how it works. When I get sick, I should go to the doctor. I shouldn't go to the Sayyid and Sheikh and ask him to pray for me. Prayer plays a major role, but after taking the right step by seeking medical treatment. And I always say to those who are in need of medical treatment, when they come to me and ask me for a hijab, for dua, for some kind of spiritual intervention, I tell them that's fine, I will do that for you, providing you go and see the doctor and seek medical treatment.
Thank you so much, Syed. We're going to call Dr. Yusra and Sister Iman back up to the podium. Oh, we do? You have a question? Yeah.
Assalamu alaikum. My question is, you are enlightening us with the cancer and cancer patient. Do we have any what you call it, the fundraising for the people who are needed for cancer patient, for cancer treatment? As we know, in this country, unless you have insurance, it's going to be hard for anyone to basically go through the process. Now, based on what I'm hearing here and based on your Islamic Initiative for America, are we having a system in place for the donation, or are we going to have a system to helping the needy in this treatment?
Thank you.
So I want to start by answering this question by saying that we have wonderful social workers that work with us in our clinic. Of course, you know, health insurance is very, very important. So I would encourage everyone to make sure that they have health insurance against cancer. Just last week, one of my patients had a lapse in her insurance and wasn't able to get chemo because it was estimated that it was going to cost her $50,000 for just that one session. You know, so we were able to push her back until she gets re-enrolled in the insurance. So it's very important to have health insurance. But I want to add that even for those without health insurance, they can get screening mammograms through the BCCCP program, okay? So that's important. It shouldn't prevent you from getting your screening mammograms. Screening is completely covered by your insurance, that you wouldn't pay anything for screening mammograms. And for majority of, you know, the healthcare, I should add, the other thing is that there's a lot of foundations for breast cancer survivors or anyone having breast cancer treatment, that there are, you know, charity and foundations that can be offered to help pay for bills or to help, you know, with if there's any problems getting medications, for example. We use foundations to help with those. And our social workers work very closely with us. So if there's any problem for covering medical expenses, to mention this early during your, you know, consultation with the doctor, because there is help.
Thank you so much. So Dr. Yusra and Iman will...
I'm sorry,
yes,
can
go
I
ahead,
add
sir.
one more thing?
Of course.
Here at the Islamic Institute of America, we have a charity fund that disperse over $50,000 average every year to needy families and individuals. Part of what we give to people is to pay for their medical bills. Obviously, we don't give a lot because of our limited resources, but that's all we can do.
Thank you so much, Syed. I want to give a special thank you for Dr. Iman Shao and Sister Iman Hazime for all the work in putting this program together, and we will conclude with a comment by them.
Thank you so much for your active participation from the audience. I would like to give a special thanks to our guest speakers who took the time this morning to come and join us. We also have a few kind of sponsors in the community and collaborators who Sister Iman will mention.
Before I thank them, I just want to remind everybody, if you can please fill out your survey for us, that would be wonderful. There's a pre on the front, I hope that was done, and a post on the back. That would be very useful to help us in the future and to understand. So also I want to thank our collaborators, the Islamic Institute of America's Women's Auxiliary Club, the Muslim Education Community Center in Canton, and thank you to Sweet Treat Events for providing all the refreshments outside that you saw at the table as you were walking in. That was very, very kind. Thank you to our panel, patient panel, Zana Al-Hassan and Ayat Faraj, for their sharing their very personal stories. Thank you all for coming out and supporting and being here.
And just please be on the lookout for further announcements from FCHI. Really hoping, cancer care is near and dear to my heart, so really hoping that we will have more events like this covering topics of lung cancer, colorectal cancer, which are also kind of the two top other cancers that we see in our communities. And like Sister Iman mentioned, just flip the surveys over and please give us your post remarks of what kind of topics you might want us to cover in the future as well. And with that, we will close. Thank you so much for coming out tonight or today.